All right, welcome back, everyone. This is the second to last lecture of the class. It's been a weird class and strange. I don't know how to even describe it. As you know, I'll say something more eloquently in an email. So I do want to just get right into the class and kind of how we're gonna wrap this thing up. So, I'm sorry, I've got a cat running around here that may make an appearance. Okay, so first of all, the final exam will be a week from today, so on April 30th, which is next Thursday. And again, I'll open up the exam for the whole day. You'll have a couple hours to take it. Same basic format as last time. It will be covering chapters 2, 3, and 4 in the associated lectures. Just a quick thing there. I'll be focusing more on chapter 2 on healthcare and personal health on the exam. Just given everything that's going on with COVID-19, healthcare in the United States and around the world, it just seems like we should spend some time on the topic. So I'll be posting the study guide for that later, and as you'll see, there will be more terms from chapter 2 and the lecture. So some of the stuff that you don't find in the textbook will be in the lectures. So there will still be stuff on drugs and crime, but not as much. And again, I didn't really have time to finish the lecture on drugs. So if there's time, I'll try and fit that in on Tuesday. But there's just a lot I do want to cover regarding healthcare, personal health, mental health, and obviously with COVID-19, obviously there's the health problem itself, but then there's also the additional economic effects and then social effects, isolation. What does this mean? So I've been spending the last couple of weeks in particular looking at social networks and the effects of isolation and things like that. So what I'm going to do then is probably spend today kind of talking about COVID-19, healthcare systems in general, and then kind of talk about personal health and our personal mental health and physical health and how it relates to the broader social system for the final lecture on Tuesday, which I'll upload, which I may record on Monday and upload then. I'll at least upload the slides on Monday, maybe even the video too. Okay, other announcements. The group project is due tonight at 11:59 p.m. I know that some people have not been able to get in touch with some group members. Some students are are in very adverse circumstances right now, maybe dealing with deteriorating home conditions and so on and so forth. So I think you've all talked to me already, and I've kind of worked with you. So anyway, if you are having any questions, just let me know. Just email me, and I'll get to that as soon as I'm done recording this lecture. Okay. All right, so as I said, pack back the discussion posts, and the last one will be due next week. Again, I think the topic is healthcare and health and so on. So I think it's a very appropriate topic for the final discussion of the semester of the class. The last mind taps are due on Monday as well. Let me know if you have any trouble accessing those. I sent out an email with describing some of the issues that have been going on, so I don't want to go over that again. But you can read the email and just know that that I'll be adjusting and fixing those things. Well, the many experiments this semester. Okay. All right, so social problems. We're wrapping up the class. I just found this image. I thought this was kind of a kind of an interesting social problems image. A bunch of people gathering together in sunlight, at dusk or something. I guess this would be a social problem right now in the era of COVID-19. People gathering together in groups like this, spreading disease and so on. Okay, so anyway, more seriously though, I am going to start by talking about just a little bit about, pandemics, about infectious disease spread and things like this. I'll talk about this a little bit more too on the lecture on Tuesday when I talk about personal health and friendship networks and things like that. If a couple of great resources. I know you can't really be probably ordering a lot of books and stuff, but maybe you want to listen to some audiobooks. If you're sick of looking at screens and things like that. Or you can do what I just did. I just got finished watching the last lecture on the great courses, Introduction to Infectious Diseases. And the last lecture is pretty interesting because the professor is going through the different types of different, pandemics that are kind of currently out there, and which is, likely to be the next big global one, or the epidemics that are out there, I should say. And, he said, well, coronavirus, the incubation period, we can usually, catch it soon enough. Oh, I got a cat that's meowing somewhere. Okay, anyway, sorry, I don't know if you can hear that. And anyway, he's kind of asking what people thought they, would be the next one, and here we are. But very, very informational. I've learned a lot from watching that. The Great Influenza. This is a very good history of the 1918 flu. That was, really the most recent global pandemic, and that's in some ways most similar in the sense that you had industrialization by that point. You had similar sort of living conditions, and you had the beginnings of similar transportation. A lot of differences, but nonetheless there are still things of value that you can learn there. So sociology here is very useful. One of the things that sociology does in terms of the sociology of health and medicine is basically the field of epidemiology, where we're studying this spread and the way in which diseases and illnesses and so on get spread through populations. This means we have to take into account a whole bunch of different things, like where people live, and the things that we're all everyone's all of a sudden an epidemiology student across the world. And we're starting to learn things about density, places where there's greater density, where we're likely to see disease spread faster. Places where there's a lot of crowds, that sort of thing. So epidemiology, it also looks at populations that are at risk, people that are already less healthy, the elderly, that sort of thing. So epidemiology, these are it's basically the sociology of illness, and how sociology can help us understand how health problems spread. Now, I've talked about John Gray before, kind of pessimistic philosopher, I would say, kind of realistic. He provides a sort of a corrective on the sort of the notion of stability. We kind of developed this idea of this stable world in the West in particular over the last few decades. And, there's nothing stable about the last few decades. It's been completely abnormal in terms of human history. Gray writes about this and a lot of other things in this book from 2003 called Straw Dogs. And I was just kind of paging through it and came across this line, epidemiology and microbiology are better guides to our future than any of our hopes or plans. You can think about that in terms of the hopes and dreams that, various, companies, governments, individuals had a few months ago, a few years ago. Epidemiology, probably would have given us a better idea of what realistic possibilities could have been. Gray himself has a new article that I think is quite good. It's I think is worth reading. He's British, so it's he kind of focuses more on the British context, but he does talk about the broader situation about COVID-19 and what it means for our social systems, our culture, globalization, all of these things. It means that a lot of these things are going to change a bit. Other thing that we talked about earlier in this semester that I want to bring up again that I think is relevant once again. We talked about it before in the context of science and technology changing society so much, and just radically shifting things so rapidly that the old postmodern theorists came up with this term called hauntology, that Mark Fisher, who was a British theorist who committed suicide a couple of years ago, he kind of built on this idea, and his writing is I think is pertinent for the moment because he talks about loneliness, alienation, the modern world, how it makes us sort of alienated. And he talks about hauntology a lot. And I think that's, we're really, hauntology is very relevant now because, as I say in this sort of update of the slide from the previous lecture, it's a characteristic of the contemporary world, but is probably even more so of one now than was the case, back in back a few years ago, or back a few weeks ago even. As we're going to mourn things that we're not able to do, and inevitably there are going to be things that are going to be big changes that we're just we don't know what they're going to be yet. But already I miss the classroom. I'm missing all of you. I miss meeting students in my office. Zoom is nice, and I'll explain why I'm not using it maybe at the end of the class right now. But I'm going to miss commencement and a lot of things, and hopefully we can come up with a vaccine. But again, things are going to change, and I think this idea of hauntology is relevant. And some of the writings by Mark Fisher, again, some audiobook to download if you're bored in quarantine. So one of the things that I want to stress right away is that what we're experiencing now, what the world is experiencing now, is very shocking to us. And we're, really knocked over, bowled over by it just psychologically. It's hard for us to comprehend. We see the protests that are going on in the United States, a few other countries. The protests against the government lockdowns, against social distancing, primarily at American state capitals, and so on and so forth. Now, the thing is, what we have to understand, and I think if we understand this sooner, the easier it is for us to move forward. And I'm going to emphasize this again when I talk about our personal mental health next week. But we have to think of this as kind of like a plague. The coronavirus, although technically not a plague medically, just socially it has basically sort of the same effect. And if we look at, I've just listed a few of the big pandemics that have been really devastating to societies. There's a classic book called Plagues and Peoples that kind of goes through kind of one of the first major accounts of how disease really impacted societies. So this Justinian plague, which happened in the mid-500s, basically, helped end the Roman Empire. The Roman Empire, it wasn't that alone. It was, collapsing social systems, overextension of military, et cetera, all these different things. But it was also, a huge plague, a huge pandemic that went through the empire and, kills lots of people, disrupts the economy, it's, things what we're seeing right now, and so on and so forth. Excuse me. So that was especially devastating. You get the Black Death, which is very, very, very well known. I think, and more well known than the Justinian plague because it's more recent in Western civilization. The Black Death was the bubonic plague that spread through rats and into humans. Basically, really hitting Europe especially hard in the early 1300s. You've got a whole bunch of different influenzas and pandemics that have happened, but another big one that happened that a lot of people aren't as aware of in Europe and the United States is sometimes what's called the third plague pandemic, which happened in the late 1800s and early 1900s and killed millions of people in China and India. Excuse me. Really devastating pandemic then. So here's looking at a number of the various pandemics and plagues and so on throughout history, and you can see the devastation that are caused by these various diseases. Sorry, I don't know. My cat is really loud. I don't know if you can hear. I guess I'll find out in the recording. Okay, Willow. Maybe she'll come make an appearance. Okay. So, the plague also, one thing that's not often discussed is the role that the environment plays. And environmental destruction. So, environmental destruction plays a big role because it brings us into closer contact with other animals, and that increases zoonotic diseases that spread from animals across species and so on. So, we don't know quite the origins of the COVID-19. It appears that bats may have been involved, and that's quite likely. So again, the environment plays a role. Also, climate change. As the weather warms, we're going to see tropical diseases spread too. So, COVID-19 isn't the last, plague or pandemic that's going to hit us. So, pay attention to the environment. I know right now everyone's talking about all the great stuff that's going on with the environment because of the lack of human activity, but that maybe is likely to be short-lived unless we really change our systems. But think about the environment also in terms of how it affects us, and I'll talk about this more in a moment. Just some, just some books if you want to look sort of historically, because I do think it's important to think historically about how illness has impacted societies in the past. And I think looking at how it affected the Roman Empire for those of you in the United States might be particularly interesting because in some ways America and Rome have some similarities. Powerful empire militarily, advanced technologically, fine arts and so on, but also a lot of debauchery and gluttony and so on and so forth. So anyway, I would recommend again some resources to check out if you're if you're bored during quarantine and want to learn more about this topic. Because as I said, the reality is that war gets more attention, and I've spent much more of my time and my thought when I think about human suffering and so on, thinking about oppression and thinking about warfare, especially in genocide, as we've talked about earlier. But throughout history, disease has killed way, way more people, and it's just been far more disruptive, generally speaking, and it's happened, quite frequently too. So this is the pandemic we're experiencing, while new to us and new to the species, is the impact of a pandemic is not something that's new, and that's just we need to remind ourselves of that. A couple other more resources on the topic. Again, I think I may have talked about this earlier, but Europe was able to conquer the world not so much because it had greater technological or military superiority. It did in some ways, but for example, it conquered the Americas not because of that. Its supply lines would have been way too stretched. It could not have gone too far into the coast, too far from the coast before you could have easily cut off their supply lines, and then the Europeans would have died in the Americas, because there were tens of millions of other people there. The guns were not that advanced at that time. So what really allowed the Europeans to conquer the world was the spread of disease. How did that happen? Well, Europeans had lived in close quarters with animals, with domesticated animals. And because of that, they were able to, and because of living like that for thousands of years, they were able to develop immunities to a number of diseases that had developed. But kind of like COVID-19, they could be carriers of those diseases and spread them to people who were not immune to them. There's this book, Ecological Imperialism. That's kind of the classic work on it. You can also read the book Guns, Germs, and Steel, which is a great work on it too. But you can also watch the video. There's a documentary on it that's very informative. That again, something to watch while you're on lockdown. Willie, just trying to see if my cat will come make an appearance. I'll pause and bring her. All right, everyone, I'm back. This is my cat Willow. She's just meowing loudly. My wife is on a conference call upstairs, and Willow doesn't like all these doors closed around her. So anyway, she only has one eye, but it doesn't slow her down or stop her or anything like that. So anyway, I'll just kind of hold her for a second. So yes, we were talking about disease passing from animals to people. This is what we saw happen in. Whoa, you can hold her kind of like a baby. This is what we saw happen in when Europeans went to the Americas, as you can see. All right. Sorry, Willow. Okay, so as you can see, Americas brought a lot of things to, Europeans brought a lot of things to the Americas, and then they took a lot of things from the Americas, and brought a lot of things from the Americas back to Europe. But some of the things that they did bring over to the Americas were livestock, but also all these diseases here that you see listed there. And they had developed immunities, whereas there were no domesticated animals in the Americas for ecological reasons we won't go into right now. But that's just kind of a fascinating aspect of human history, and just kind of showing how disease has played a huge role in how our world has been shaped. A series of fictional works, that I think are relevant. My personal favorite right here is Margaret Atwood's book Oryx and Crake, which is the first book in a trilogy. Fantastic. It blew my mind when I read it about 10 years ago. Anyway, if you're bored, thing for you to do if you're just want to know about this subject some more. Okay, now looking more at it sociologically, looking specifically at COVID-19, looking at the gender aspect of the healthcare, a lot of the people that are on the front lines of fighting COVID-19 are women. That goes especially for nurses and so on, and people who are working in elderly care facilities and so on. So women are on the front lines of this. Now, when we look at the deaths and cases by race, I think it's important to point this out. We have a majority white population in the United States, but we have we're seeing a very disproportionate number of cases, and especially of deaths of African Americans from COVID-19. So this is pretty alarming, and you see the deaths is basically statistically about the same as that for white people. So what's going on there? Well, we'll kind of get there in a moment. So just kind of show it again. Looking at these different states or cities and So this is African American share of state city populations and COVID-19 deaths. So African Americans make up 32% of Louisiana's population, 70% of COVID-19 deaths, 22% of North Carolina's, 22% of their deaths. So that's actually the only place where you see it somewhat reflective of the reality. Chicago, very, very disproportionate there too. 30% of the city's population, again, almost 70% of the deaths. So that's alarming there. And we see this basically, again, you see a breakdown there. This is looking at Evanston, Indiana. For other groups, it's roughly about the same. Hispanic, it matches the population. White people have, they're 60% of the population, and they're responsible for about they have about a third of the cases. African Americans only make up 16% of the city's population, but make up over a third of cases. This is South Carolina's distribution. This is looking at cases, so again, not deaths, but just cases overall. I don't have the actual demographics in South Carolina, but the black population is not 36%, or it's much lower than that. So we see again a huge disproportionality in African Americans being hit. This comes across not just in the hospital reports, but in survey data and in fairly recent survey data. So African Americans are much more likely to know someone who has been hospitalized or died as a result of COVID-19. You see for white people, 13% say yes. For African Americans, it's 27%. Pretty significant difference. Significant difference there. So what's going on here? What are some of the reasons for this? Get to that in a moment. Another sort of sociological demographic factor to consider. Really, across the world, we're seeing this, that in terms of deaths at least, we're seeing that men are dying at much higher rates. As you can see here, it's really significantly higher rates than women. I don't know why that is, and I don't know why the variation is so large between some of these countries. For example, why is it so much different in France from, say, Denmark, or Germany and Denmark, which border each other, or actually Germany and Denmark are somewhat similar. But even still, nonetheless, you still have a 5% difference. That's interesting and unclear why that is. And why it's hitting men, I don't know that yet. Men are at greater risk of number of health conditions. Well, let me back up from that. As I'll say in a moment later on, that actually women have more health conditions, are at greater risk, but men are at greater risk of some of the conditions that we see being really contributors to death in these circumstances. Now, interestingly, even though men are at greater risk, significantly greater risk of death from COVID-19, we find that women are much more likely to worry about the negative consequences of coronavirus, except with regard to investments. So you basically have women who are more worried about someone else getting sick. They're more worried about losing income, about not being able to afford testing, and so on and so forth. Now, again, there's very interesting reasons for this that we've kind of talked about when we talked about gender in the past. Men, don't seek out medical treatment often, and that's one reason why men one reason why men die earlier. But again, some of that is complex. Excuse me. So this was looking at data coming out of China, looking at death rates from COVID-19. The vast majority happening in the elderly, but again, still fairly high rates for people who are younger than that. And then happening to, again, we see the same patterns with it happening to men more. We also see a number of conditions here. In China, at least, the main conditions that were linked with it were cardiovascular, diabetes, respiratory disease, then hypertension. Now, so this was one of the first kind of comprehensive studies that came out of China, looking at some of the demographic aspects of this. Now, a study came out. It was just reported this morning in the New York Times, and you can find the actual journal of blah 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 whatever JAMA. But anyway, this is a study of the 5,700 patients in New York City. They found that about 20% of those hospitalized died. It was worse for those who were put on ventilators. 88% of COVID-19 patients put on ventilators died. Usually about 80% of people who are put on ventilators die. So this means that it's worse than, the normal pneumonia conditions or whatever people are put on ventilators for. 60% male, 40% female, the average age 63. But again, a lot of younger people were coming in, so that's, even though a lot of people again, let me back up. When we look at China, a lot of the death rates were on the higher end, older end, I should say. This might be being pulled down by lower rates. I'm not sure. Need to read this study again more closely, but I'll link it in the modules if you want to look at it yourself. So again, a breakdown. So again, if you remember the breakdown here in China, cardiovascular, then you had diabetes, then respiratory disease such as asthma, and then hypertension. It's a little bit different than what they found, at least here in New York. 57% hypertension, then obesity, then diabetes. Asthma and other respiratory diseases were not near the top of the list. Now that's kind of interesting. I have asthma, so this, I've been worried about COVID-19 as someone with a respiratory disease. It does not mean that, you're going to be fine if you have asthma. No, it can still be, a death sentence, or at least, put you in the hospital, or, just make you miserable. So at least though those who are dying people who have hypertension, obesity, and diabetes. I'll talk about some of these in more detail in a moment. What's my theory about this? Well, my theory is that asthma, we're starting to identify a number of subtypes, whereas obesity, for example, and hypertension, they can result in a lot of other systemic problems throughout the body that you might not see, whereas sometimes asthma can just be situational or, affect you when you're having an asthmatic issue. Sometimes it's completely debilitating, and sometimes it's coincides with these other health issues. But right now, it looks like, obesity, hypertension, a lot of things that we see linked to lower income groups in our society, and that's one reason we might see it hitting. I don't know the income data yet. I don't know if any. I'm pretty sure none of that's been published yet. But that'll be interesting to see the correlations there. So in my intro to sociology class, we're reading this book called Connected by Nicholas Christakis. He's one of the world's experts on social connections, and he's a physician and also a sociologist. I may have mentioned him earlier. I know there's some links to him in the COVID module. But I've been going through his work lately, and I'm just going to briefly talk about social networks because he's one of the top experts on social networks and how we need to be connected to each other. But he's also one of the top people saying, but we need to be at least physically distanced and disconnected from each other. So I'm going to talk about this a little bit more. I'll return to this, I think, on the next lecture, because we're all sort of alone and isolated, and how do we maintain our friendship stuff and so on. So anyway, I'll kind of return to this, but just I do just want to kind of point out that these are what social networks are. And epidemiologists are familiar with these sort of things. So these nodes are actually people. This is actually a network, a social network, so a number of people over time. Those yellow, each dot there is a person. We call these nodes. Oops, I'll get myself out of there. And each of these is a node. The lines are the relationships between people measured by maybe their degree of relatedness, or are they best friend, second best friend, cousin, whatever, that sort of thing. They figure out some way to quantify that. And what this is actually measuring is the spread of obesity. So this is actually after a network has spread, obesity spread through this network for 30 years. And it spread like a virus or something because of changes in social norms and behaviors and so on and so forth. So where you are in a network kind of determines a whole lot of stuff about who you are and what happens in your life. So people generally who are on the edges of networks tend to be introverted or a bit more lonely. And then people in the middle, not always, but sometimes are more extroverted and so on and so forth. When a disease is spreading through a network, you actually want to be toward the fringes of the network because you're more likely to be hit if you're in the center of a social network. I'll sort of return to this when we talk about loneliness in the next lecture. But anyway, this stuff is just there because it's kind of important for understanding just epidemiology. Okay, so kind of talking about systems, healthcare systems. Most of you are on your parents' healthcare. And maybe wondering what happens after you turn 26 and then you're no longer on their healthcare. And some of this may be determined by what happens with the next presidential election, the future of what happened with the COVID-19 response, and so on and so forth. So one of the big questions right off the bat, that we would normally have, an interesting conversation in class about is access to healthcare a right or a privilege? And, the general thinking in the United States has been that it's a privilege. In European countries, that it's a right, with other countries having kind of variations of this, as we kind of talked about with how some countries, require children to take care of their elderly parents. So I'll let you think about this, and you probably had some thoughts about this already. You kind of have a excuse me. Kind of gets back to that kind of libertarian versus utilitarian sort of kind of classic debate, which is has become much more fundamental and much more interesting with COVID-19 happening. Kind of in my last lecture next week, I'll kind of speak to that a little bit. And, something, also to think about, has COVID-19 changed your views on healthcare access and provision? So maybe, a month ago you thought, it should all be free market, and now you think it should all be government run. Or maybe, you thought it should be a privilege, now you think that it's a right. Or maybe the opposite, that maybe you think now that you think that it should be something that's a privilege, that the market provides. The government should get out of here. The government has proven that it's inept and incompetent, and private industry would do it more efficiently. Again, COVID-19 will probably force us into a more utilitarian approach, just because we are social organisms, and so we do tend to act in that direction. The question is, do we do it in a collectivist utilitarian way, or in a more libertarian utilitarian sort of way? And I'll speak to that again later. Just looking at life expectancy, again, the differences between ethnic groups is pretty stark. This is just looking at between blacks and whites over the last century, and you see the life expectancy has improved for everyone, but it's improved much more dramatically for white people. In terms of the American healthcare system, we have to just be honest, and as you'll see when we look at the numbers, it's just kind of a failure on many levels. Like this meme about this show, Breaking Bad. All you need to know about the American healthcare system is that there's a popular TV series where a man turns to cooking industrial quantities of crystal meth in order to pay his hospital bills. Good show, Breaking Bad, but yes, a sad commentary on healthcare in America. So healthcare was already expected to make up a huge percentage of the economy by this year, during this year. Now more with COVID-19. Whatever parts of the economy that run are going to be what are now being called essential services, and healthcare is definitely going to be one of those. Now, what kind is going to be unclear. You can't really go see a dentist or go see, a regular checkup. So it's going to be, as I said, the healthcare sector of the economy will grow, but in some areas it will shrink. So again, it'll be just kind of unclear right now what's going to happen as we try to head off this crisis. The United States, though, we spend more money on per capita on healthcare than anywhere else in the world. Nevertheless, our life expectancy is 27th, and it's been falling the last few years. Now, many other countries can achieve higher life expectancy with much lower levels of spending. So I think one of the things that we need to look at are some of the macro practices in healthcare. Oops. Okay, so first of all, some of the things we need to understand. Expenses are rising dramatically. There's unequal access. Some people have, great access to healthcare. Others do not. There's all sorts of, say, use the word plagued, healthcare workers and others. There's all sorts of ethical dilemmas, and these are even bigger now with COVID-19, with doctors having to make decisions on who gets a ventilator, who doesn't, who gets treated, who doesn't. We're going to see shortages of drugs and things like that. So again, these are big issues, because these are ethical, moral issues. And then there's healthcare and cultural competence. Where parts of America have done a very good job in terms of social distancing. Others have not. We're seeing how this plays out. So when we look at sort of the broader medical costs, why are medical costs in the United States in particular going up so much? They're going up everywhere for these basic same reasons too, I should say. Well, as people live longer, they need more treatment. These costs of services, mean more technology. The cost of drugs are going up in the United States in particular. Some of that has to do with FDA regulations, FDA red tape. Others have to do with companies knowing that they can make a lot more money in the United States than they can elsewhere. It's a combination of those two. You kind of have to tackle both of those. Health insurance is a big one. I think, that's the one that really prevents a lot of people from going in and doing things preventatively. So Americans wait until the last moment generally, because they know that they're going to get a big bill. And usually they wait until, it's too late, and, then it's just the condition is worse, and so on. So Americans don't do much don't receive a lot of preventive treatment or seek it out, and so on. So when we look at the spending in America, again, when we look at debt levels, this is the types of debt that are collected. Student loans are up there, that's a big one, but, people can actually pay them off relatively quickly. Well, I shouldn't say relatively quickly. Some people are paying them off forever. I'm still paying them off, and so on. But anyway, credit cards, they take up a big chunk, but healthcare, 38%, just dwarfs all the other forms of debt in the United States. Now, when we look at healthcare systems, so really, most healthcare systems around the world are a mixture of, excuse me, some form of public and private system. So you see, so here you see the light blue is public and the dark blue is private. This is 2010, roughly the same today. Not a big difference for what I'm talking about here. The one thing that you do notice that's perhaps, I think, different than anywhere else is that the United States has by far the biggest private sector of any country. Really, most of these are European countries, but even, South Korea, Japan, you've got, much bigger public sector involvement. So that plays a big role. And, just objectively, it's a problem. It's a problem because it causes you have a almost solely for-profit model then that's sort of strung out across the entire system. Now, as you can see, there's nowhere where you have a complete public system, at least, outside of communist countries. But you have countries where the government, the public, played a much bigger role. So that's why it's been easier for countries like Japan, South Korea, Denmark, Italy, and so on, to contend with their COVID-19 outbreaks. The United States is having a hell of a time, and some of it has to do with a lot of it has to do with the structure of our healthcare system. So again, just I kind of went through some of this, but this is just another kind of look at the numbers, look at the reasons why healthcare costs are going up. Now, as I said, the United States, that slide was in there, kind of weird. Okay, so the United States, as I said, we spend more per capita, but our life expectancy isn't necessarily the best. So this is spending down here on the x-axis. On the y-axis, you've got years, life expectancy. The United States, we're way out here in terms of spending. We spend way more than anywhere else. But look, other countries, you know, a lot of European countries and so on are able to spend much less. Japan, you know, and other countries spend much less and achieve, you know, even better life expectancy. So, you know, we spend a lot of money to achieve the same average life expectancy as a lot of countries that are comparatively much poorer and spend much less money. This is just another kind of same way to look at it. Average life expectancy here on the y-axis. On this side, down here, you've got different countries. Over here on this axis, you've got per capita spending. And then the bars are life expectancy, and then the purple lines are life expectancy. So again, you've got the United States, big outlier, spending lots of money, but really not, you know, here we are in terms of life expectancy. You know, Denmark, you know, we're a little bit below Denmark. We spend way more than Denmark does, though. So something's rotten, not in Denmark, but in America. The line is, there's something rotten in Denmark, from the Shakespeare Hamlet play, but you know, Denmark is doing a pretty damn good job when it comes to healthcare. My Danish relatives, I have a lot of family who are Danish, they are just continually just shocked, amazed, just dumbfounded by the cost of healthcare in the United States, and you know, are just asking my wife and I to, you know, just come live in America, just come move to Denmark, you know, it's much better, healthcare-wise at least. You know, maybe. Okay, or at least maybe we should learn something from them. So here's another problem that's kind of really frustrating with America's healthcare system. We have a lack of doctors in this country. So since 1910, the American Medical Association has basically been lobbying to reduce the number of medical licenses that are granted, keeping it at about 100,000 a year. You know, there's been some fluctuation, but not much, meaning that there's always a shortage. So this is really frustrating and stupid from the perspective of public health and epidemiology. But from the perspective of, you know, the bank accounts of the doctors, I guess, you know, it's this allows American doctors to be paid twice as much as the European doctors. You know, I mean, I guess I've got some big bills I need to pay, you know, to some health officials in at Penn State Health, Hershey, you know, so that they can feed their families on their yachts and stuff. Okay, so anyway, so this is a big problem. This is ridiculous. We need to be granting more healthcare licenses. We also need to be training doctors to be learning how to excuse me, to learn how to understand some of these systems a bit better. When I say some of these systems, I mean artificial intelligence. So I'll get to this in a moment. So we're probably going to see this change as a result of COVID-19. We're graduating med students faster and a whole bunch of things like that. So right now, I think my mom was an emergency room nurse, and then was a nurse at a college for a while before she retired. And so, and I have friends who are nurses. I have many students and former students who are nurses, and these people right now are like they're like the military in a war. They're on the front lines in this battle, and they're being hit. They're dying. So this is a big problem because we do not pay them equivalent to how much their importance for our society. They are an essential service. We're starting to realize that, maybe the market does not adequately pay people. It has not been adequately paying people for their services to society. So I'm very frustrated that nurses have not been getting nurses and doctors, everybody working at hospitals and in healthcare have not been getting the protective gear that they need, that they have not been getting the government preparedness that they deserved. And we're going to see what happened in New York City probably happen in other smaller places that don't have the same resources. And we could see this, we're likely to see this hit even worse next winter during flu season and correspond with the flu. I mean, it's going to be rough. Okay, so big changes in healthcare. One of the biggest changes of the last few decades was the Affordable Care Act of 2010. Looks like Joe Biden is going to be the Republican nominee, the Democratic nominee for president, opposing the Republican nominee, Donald Trump. When this bill was passed back in 2010, Joe Biden was vice president, and a mic caught him saying to Obama after the passage, "This is a big fucking deal." And it was. It changed healthcare. All of a sudden, it became possible for everyone to have universal healthcare in the United States. It also generated a huge backlash to government intervention. It helped ignite the Tea Party, which has been a movement that has been focused on smaller government. Some of the Tea Party has been sort of involved in the anti-lockdown protests, and so on, and so on and so forth. So the Affordable Care Act. Big deal. As I said, established universal care. Nevertheless, there are a lot of problems, a lot of things that people don't like about it. It comes, everyone kind of pays for it out of higher insurance expenditures. People who are more healthy pay a bit more. And so on. So, very controversial. It'll be interesting to see where we go from here. Bernie Sanders, when he was running for the Democratic nomination, was famously advocating a single-payer system. Joe Biden has kind of moved away from that. Single-payer system, just so you know, the difference is kind of laid out here. So the top is kind of what we have right now. Patients, you pay premiums to insurance companies, and they pay the providers, the doctors, and you pay a copay to them. And then the premiums, we've seen premiums have been going up, and that's been like the big rise in America, is that premiums to insurance companies have been going up. Now, in some companies, in a true single-payer system, you would pay to the government. The government pays directly to the provider. This is paid for. How does the government get its money? Through taxes and so on. But you don't have private plans. Speaking of health and so on, if you remember, I think in the lecture on science and technology, I said something at a slide about doing shoulder exercises. I usually would be getting a massage by now, but anyway. My shoulder hurts from having to look at this computer screen so much. Okay, so anyway, a single-payer system model, you have the government paying for most of it. In most countries, though, like the United Kingdom, Canada, Denmark, countries that are closer to a single-payer system than the United States, you still don't have a true single-payer system, but you have pretty close. But you do have a sort of mixture. What you have instead of insurance companies are private providers, and that's where you sort of see the private sector playing more of a role. Now, so as I said when we talked about COVID-19, one of the biggest risk factors was obesity and hypertension. Obesity is a growing risk factor for a lot of health problems across the world. When we talk about total expenditures per capita, as well as total expenditures, the United States faces the biggest obesity crisis, followed by Germany and then Canada and then all these other countries. It's growing in countries that are, industrializing fast. So China is growing rapidly. Obesity in China is growing rapidly. It's growing rapidly in India as well. Why is it so high in the United States? Well, the United States is the richest country. Nevertheless, why is it still, why do we find that obesity is higher? And again, I'll be connecting this to COVID-19. Now, obesity, it's a recent thing. It's not just, obese and Americans just started gaining weight, 100 years ago or something like that. I need to set my laptop. Sorry, it's in my kitchen. Okay, set my laptop a bit higher. Okay, so obesity back in 1990, you didn't have any state where over 15% of the population was considered obese. By 2008, already over 32%. 32 states had 25% obesity. So it's problematic too. It's such an annoying thing. In the United States, 60% of Americans are overweight. We're leading the world in obesity. We've been kind of dragging the world along by selling them our sugar-filled products. But we still have this powerful stigma against obesity. And one of the things too about obesity is that we tend to think of it as a very individual thing. And there are individual factors, of course, and we make our own decisions. But there's a sociological dimension to it. And, when we look at obesity trends, you look there at the colors here, dark blue meaning, 15%, excuse me, between 15 and 20%. And then purple meaning between 20 and 25%. So, and you can see, et cetera, then, places that have more than 30%, 25 to 30%, and so on. So you see the change that happens basically from the 1990s on. And you can see where it's geographically located as well. It's overwhelmingly low, the obesity epidemic, as people are calling it, rightly, because it spreads through social networks and across social networks too. Is centered in the Midwest and the South, especially. You can just see the change from 1990 to 2010. Huge changes, especially for the South and for the Midwest. Now, the sad thing too, especially, is that in the South, a lot of the healthcare systems are not very, very strong, and there's a lot of poverty there. And so as we see COVID-19 is probably going to hit the South really hard. They're opening up way too quickly. They didn't shut down soon enough. So we're probably going to see huge outbreaks of COVID-19 in the coming weeks in the South. And I think it's going to be really tragic what happens there. Hopefully we won't see it, but I'm worried that the trends are already looking that way. Okay, when we talk about eating disorders in general, the vast majority of eating disorders are held by women. 20% of people who have anorexia will die from anorexia. So this is a serious psychological condition, and sometimes it's kind of mocked or demeaned in popular culture, but it's a serious psychological, maybe biological illness, psychological illness at least. Excuse me. And when we look at our diet culture, you can sort of see why. 45% of women are dieting, 60% of girls age 13 diet. If you remember when we talked about technology and how young girls' suicide rates and depression rates are just skyrocketing for young girls in the United States right now. And a lot of that has to do with social media, but social media is showing images of, in their eyes, better looking women or better looking girls or whatever it might be. So I think this, again, is an alarming statistic. 60% of girls age 13 are dieting. If it was just that, 60% of girls age 13 are eating healthy, then I would be happy to see that. But dieting doesn't necessarily mean eating healthy. There are very unhealthy diets, and people have different metabolisms and so on and so forth. So that's actually alarming. I don't like to see that. Over 80% of something, and I copied something from a Word document, and it was obviously a dramatically large number that I don't know what that means. So forget about it, I guess. Okay. So when we look at obesity, a lot of it's tied to income. So this is looking at the quintiles, bottom poorest, and you've got the top fifth richest here. Now what's kind of interesting here is obesity is highest in the bottom quintile and basically goes down as you go up in income. Oops. But just being overweight, that's not necessarily the case. It's not quite the difference, the same, but you almost have it going up, not quite, but almost going up from low to high, from low income to high income groups. So that's really interesting. What that means is that there are a lot of people who are who are middle class or wealthy, who are overweight, and I would be in this category. I'm technically overweight, but are not obese. So people are that's why you see 60% of Americans are overweight. I mean, and you see this across the income scale. But you still see a lot of this negativity towards people that are obese, and a lot of this has to do with attitudes towards people who are poor and things like that. So obesity, there's a term in your book calls it globesity, kind of referring to this global spread. And I'll wrap up this lecture right here in a moment. Okay. Yeah, so it's spreading across the globe, kind of talked about that. Again, the thing that I want to stress that we have a huge population of people in the world now, and we have a diversity of body types. And in the West we have sort of idolized a certain image over the last 100 years that looks something like this. When if you look at the paintings from the Renaissance era, people thought this was beautiful. More voluptuous. What we would consider as being more overweight, almost obese. That was a high standard of beauty at that time. So we do have this diversity of body types, why diets don't work, and why they work differently for different people. And I think that's something we need to keep in mind. We also need to think about how we frame health issues. So I'm just going to sort of end on this, how we talk about these things, because it does matter that way. So when President Trump came out, and not just President Trump, but a lot of people were a few months ago, I should say, were saying COVID-19, this is something that hits the elderly, and you don't really need to worry about it unless you're elderly or immune compromised. And yes, those are the highest risk categories, but it turns out that it's taking down a lot of people. It's killing and seriously injuring and hospitalizing lots of people that are not old, that do not have underlying health conditions that we really know about. So how we frame these things matters, because I think if we would have said, turns out a lot of people that are, the majority of people that are being hospitalized in the United States are actually younger than 50, younger than, I think, 40 even, or at least, in their 30s and 40s, that would have changed a lot of behavior. If you find out, a lot of people in their 20s are getting very ill, and what the healthcare bill is, and, what it does long-term to your lungs and your kidneys. Our behavior would have been different. If the American government would have framed COVID-19 differently, our response would have been different. So just an example here, it's popular belief that men suffer the most from heart disease. Most of the medical establishment tends to believe this as well. So even though more women have actually died from cardiovascular related diseases since 1984, since before my sister was born the next year, basically since almost my sister's age, fewer than 1 in 5 doctors, a whole range of different doctors, in a 2005 study knew that. That's really kind of incredible. I think more people know this now, but it's still lower than it should be. So, so doctors have not been taking women's tachycardia issues and cardiovascular issues as seriously as they should, because they don't think women suffer from them as much, even though they really do. So even after taking into account men's shorter lifespans, women will spend 20% more on healthcare in their lifetimes. Some of this is a result of going to seek treatment sooner, and because our healthcare system in the United States is more expensive, women end up spending more. But it also has to do with the fact that women have more health, generally speaking, again, have more health issues than men do. Men die sooner for a range of different reasons. Women have more health issues throughout their life. Why is that? Why do women have more health issues? At the end of the day, there are different reasons. When you talk about different health conditions, it varies. At the end of the day, the biggest reason for those basic differences is that women are biologically are the ones who reproduce, and because of that, you just have a set of different immunities and systems and so on. So I'll stop there for today, and I think I'll try to upload the lecture, the final lecture, maybe Monday we'll see. But I'll definitely upload the final slides on Monday night. And the video lecture is going to kind of finish up talking about healthcare systems, and then also talk about mental health, and also talk about kind of our personal health, and kind of wrap up the course and kind of bring it all together. Bring functionalism, conflict, symbolic interactionism, libertarianism versus utilitarianism in the context of this COVID-19 climate change world that we're living in. So anyway, we're heading towards the end. I'll be uploading the study guide for the final exam later today. Stay safe, everyone. I hope you can finish this week, and we can work toward next week with as little trouble as possible. And just email me if you have any issues or concerns. Have a good weekend, all things considered.